Luba Nakhutina is next up.
Hello, everybody. So I will talk about some data from comprehensive neurobehavioral assessments in our epilepsy patients at the clinic. And we'll highlight several findings from our studies from this data set. Some of this was introduced by Dr. Grant, so that helps me not to get into that. The focus has been practical outcome variables for patients, such as medication adherence, has important implications for their morbidity, mortality, SUDEP, as was discussed previously. So this slide lists our team, collaborators, students who've worked with us over the years. And so to look comprehensively at behavior and at cognition, what this subset of participants underwent was detailed assessment of their neuropsychological functioning across these domains listed, so intellectual functions, attention, executive functioning, memory, language, and the usual domains. We also took a look at their psychological symptoms, which are quite prevalent. Most commonly depression, second most common anxiety, and other psychiatric symptoms, and measured quality of life. This is understood in the context of where the patients come from in terms of their educational opportunities that they've had and attainment with that, their employment status, considering their cultural backgrounds. So the data are understood in the context of all of that, along with some psychosocial variables. We've measured perceived stigma. Dr. Graham talked about the measurement of beliefs, and we've published about that. And so all of the relationships among these, domains, so to speak, are bidirectional, and, cognitive problems create more psychological distress, and increased psychological distress oftentimes impedes cognition. And with that, patients oftentimes struggle functionally, and the functional variable of focus has been medication adherence, measured a couple of different ways. And so Dr. Grant talked about this new way that we've tried measuring it recently. A lot of times in the field, this is measured with the MEMS cap, and I'll get back to explaining what that is, and we also have patients self-report. So the sample is a representative sample of our patients at Downstate Epilepsy Center. These were 60 individuals with, so primarily people of color, majority unemployed, about 80%, very low SES, many patients, and I've had epilepsy for a number of years. As part of the inclusion criteria, we wanted them to have the diagnosis for over a year, be on one or more anti-epileptic drugs, and be reporting 2 or more seizures in the past 6 months. So the detailed assessment of the nature that I've described with the previous slide, I'll share just, in the few minutes that we have, I'll share a few findings. So one, when we measured adherence, what we saw with the MEMS, which is the medication event monitoring system, and these are electronic caps on the bottle that have small microcircuit and records each time the bottle is open. And so with that, as the participant opens the bottle to take the dose, the time and date is noted. And so the graphs that you're seeing up there are from actual patients. And how does one move this? Okay. And so, for example, here's a participant who reliably, so accurately took the morning dose, but wasn't very adherent with the evening dose. And that's a representative pattern from many patients. People tend to forget their evening doses. So that, experientially, maybe that's common sense, but that is what we're seeing in these data. And here, the other graph here is from another patient who just didn't have any kind of routine. And so they're taking these doses. It's all over the place across these dates and times. Both patients had very low adherence. The top one, 13%, the bottom one, 33%. The top graph, the patient reported excellent adherence. So either because they were speaking to their physician and kind of knew, wanted to present it that way, or just wasn't aware, and it could go either way. And the second patient knew they were poor and endorsed poor adherence. So the correlation between objective and subjective measures varies across patients. So overall, at the sample level, perhaps tends to correlate, but at the individual level, it could go different ways. Memory testing for these participants showed borderline impaired memory functioning. And so, for example, on Hopkins Verbal Learning Test, which is a wordless learning, patient mean performance was borderline impaired, pretty low. And what we saw is that poor immediate recall of information was significantly related to higher frequency of extra doses taken. So patients weren't remembering, did I take my medicine? That moment that maybe all of us have experienced. But so this is happening a lot. And so 81% missed 3 or more doses in the sample. And 20% of patients took 2 or more extra doses. And there was no significant association with the report. So this inaccurate report of how well was I able to adhere, you would think is related to memory functioning, but it wasn't in the sample. The other way to assess memory is to look at prospective memory, which is memory for intentions. So this future event that I'm going to take this dose at a specific time. This too was poor in our patients, and so borderline impaired functioning for prospective memory. One item on that test is asking a patient to call the center and leave a voicemail the following day, telling us how many hours they slept. And so 74% of participants were non-responders. They didn't make that call in the given time frame, and that was highly associated with their suboptimal medication adherence. So that could be a quick test clinically to do with patients.
Less than a minute.
Okay, less than a minute. So turning to psychological functioning for a moment and just capturing this for you, that in our epilepsy patients, we saw that depression was highly prevalent. This is, so 41% qualified for depressive disorder on a structured diagnostic interview. And this is at the upper end of prevalences reported in the literature. When we asked them to self-report symptoms on BDI, 33% endorsed symptoms and 25% moderate to severe symptoms. Interestingly, 13% endorsed no symptoms, and yet some of those individuals, so the majority of that subgroup, were diagnosed with the structured interview. So just related to being aware of the stigma, and patients oftentimes speaking in physical and somatic symptoms terms, but not wanting to endorse depression. This was related to negative beliefs about illness. And the same as you see with the prevalence of anxiety, so highly prevalent in our patients. And these are targets for behavioral interventions that we can improve outcomes with.